This conference will now be recorded.
Good morning, everyone. Am I audible to you all? Please drop me message in chat box so that we can begin with the session. Okay. Hello, everyone. A warm welcome to one and all attending our very own Dental Academy maiden session. It gives me immense pleasure to welcome you all. I would like to just brief you all about CM Dental Academy. It's an online dental education platform in the field of dental surgery. We aim at delivering excellent quality online training programs and courses for the dental students under the guidance of eminent mentors. The undergraduate and postgraduate subjects will be covered in all the formats, such as live online lectures, descriptive notes, MCQs to prepare for your competitive exams, and Viva-OC key points will be discussed. So, what are you waiting for? Come, let's begin the journey towards success. Let me introduce to you all myself, Dr. Mayuri Kulkarni Patil. I'm an oral and maxillofacial pathologist and microbiologist. At present, I'm a course director at CM Dental Academy. So before beginning with the session, developmental disturbances of tongue, I would like to throw some light on the normal development of tongue. Once the normal is known, then you can differentiate between what is abnormal. So the development of the tongue occurs around 4th week of intrauterine life, where the two pharyngeal pouches meet in the midline, where the pharyngeal arches meet in the midline. There will be local proliferation of the mesenchymal tissue. It gives rise to number of swellings in the floor of the mouth. Once the proliferation begins, there will be small knob-like structures or the swellings in the floor of the mouth. The first swelling that arises is the tubercular impalm, further followed by two lingual swellings. You can see here. These are the lingual swellings and the tuberculum impar. The lateral lingual swellings quickly enlarge and merge with each other and tuberculum impar to form a large mass from which the mucous membrane of anterior two-thirds of the tongue is formed. Further, the root of the tongue arises from the large midline swelling. This is the large midline swelling, which is developed from the mesenchyme of second, third, and fourth arches. I hope you can appreciate the second, third, and the fourth pharyngeal arches. This swelling consists of a copula, which is associated with third and the fourth arches. As the tongue develops, the hypobranchial eminence overgrows the copula, which disappears later. The tongue separates from the floor of the mouth by a downward growth of the ectoderm, around its periphery, which degenerates to form a lingual sulcus. Once the lingual sulcus is formed here, once the lingual sulcus is formed along the tongue gets the mobility. So in short, the anterior two-third of the tongue develops by the first arch, which is supplied by the fifth cranial nerve, and the posterior one-third is developed by the third arch, which is supplied by the ninth cranial nerve. The components of the tongue, we'll study them under the following headings, such as the epithelium, connective tissue, and the muscle tissue. The epithelium of anterior two-third of the tongue formed from the two lingual swellings, which is supplied by the first branchial arch. The posterior one-third is developed from the third pharyngeal arch. It is supplied by the glossopharyngeal nerve. And the posterior most part, which arises from the fourth arch, which is supplied by the vagus nerve. The connective tissue component of tongue develops by the local mesenchyme, and the muscle components develops by the occipital myotomes, which are innervated by the hypoglossal nerve. The histology of the tongue. Tongue is a muscular organ. Bulk of the tongue is formed by the striated muscles. The mucous membrane consists of connective tissue lined by the stratified squamous epithelium. The oral part of the dorsum is thin. It has papillae and adherent to the muscles. The pharyngeal part of the dorsum has rich in lymphoid follicles. It also has mucus and serous glands which lie deep into the mucous membrane. There are two types of cells present mainly in the taste buds. The sustentacular cells, which are called as the supporting cells. These are spindle shaped. These are the sustentacular cells, which are spindle shaped, present at the periphery of the taste bud, and the gustatory cells, which are long, slender, and centrally located. And these are the basal cells. This is the stratified squamous epithelium. So now the question arises where these taste buds are exactly located. In the papillae. There are four types of papillae present in the tongue, mainly the valate papillae or the circumvallate papillae, filiform papillae, which are conical in shape, fungiform papillae, and the foliate papillae. The circumvallate papillae or valate papillae are 1 to 2 millimeter in diameter. They occur in clusters of 8 to 10 in number, present in front of the sulcus terminalis. The wall of the papillae have taste buds. So the circumvallate papillae has the taste buds. The fungiform papillae, these are present along the tips and margins of the tongue. Some are scattered over the dorsum. These are smaller than the valate papillae and bright red in color. The filiform papillae, or these are also known as conical papillae. These cover the presulcal area and conical in appearance, smallest and most numerous. They are pointed and covered with the keratin. Very easy to appreciate them. Foliate papillae. These are present along the lateral border of the circumvallate papillae. These are leaf-shaped. So this is a photograph showing all the four types of the papillae. You can see the filiform papillae. The first one, A, which shows the conical shape and presence of the keratin here. These are the foliate papillae, which are leaf-shaped. This is the circumvallate papillae, which has around 8 to 10 taste buds. You can see the taste buds present along the circumvallate papillae here. And these are called as the fungiform papillae. The muscles of the tongue. So the tongue is divided into two half sections such as right and left by the medial septum. Each half has four intrinsic muscles and four extrinsic muscles. The four intrinsic muscles being the superior longitudinal, inferior longitudinal, transverse, and vertical, while that of the extrinsic muscles of the tongue being the genioglossus, the hyoglossus, the styloglossus, and palatoglossus. The blood supply to the tongue is mainly by the tortoise lingual artery, which is a branch of the external carotid artery. A tonsillar artery, branch of facial artery, also supplies to the root of the tongue. And tongue is also innervated by the ascending pharyngeal branch of the external carotid artery. The deep lingual veins provides the venous drainage to the tongue, which further drains into the internal jugular vein. The nerve supply, the motor nerve supply is mainly by the hypoglossal nerve to all the extrinsic and the intrinsic muscles, except the palatoglossus muscle. The palatoglossus muscle is innervated by cranial root of accessory nerve through the pharyngeal plexus. The sensory supply of the tongue, we can study them under as anterior 2/3 of the tongue, posterior 1/3 of the tongue, and the posterior most part. The anterior 2/3 of the tongue is innervated by the lingual nerve, which provides the general sensation to the tongue. And chorda tympani branch of the facial nerve provides the taste perception. Except for the valid papillae, which is supplied by the glossopharyngeal nerve. The posterior most part is supplied by the glossopharyngeal nerve for both the general sensation and the taste perception, while that of the posterior most part is innervated by the vagus nerve. It provides general sensation as well as the taste perception. Now we can discuss about the developmental disturbances of tongue. I would like to brief you all about developmental disturbances of tongue under the following headings such as Aglossia and Microglossia syndrome, macroglossia, Ankyloglossia, cleft tongue, fissured tongue, median rhomboid glossitis, hairy tongue, lingual varices, lingual thyroid nodule. We'll be dealing with each condition separately. Aglossia and Microglossia syndrome. This malformation is very rare. It is associated with oral mandibular limb hypogenesis syndrome. The oral mandibular limb hypogenesis syndrome presents with hypodactylia, that is decreased in number of the digits, hypomelia, cleft palate, and intraoral bands. Aglossia syndrome is in reality a microglossia. Aglossia word stands for the complete absence of tongue, but in reality it doesn't exist so far. It presents with a small rudimentary tongue. As the tongue is small or rudimentary, the muscular stimulus between the alveolar arches is reduced or diminished. The tongue tends to put pressure on the alveolar arches, and it helps in the growth of the mandibular arch in a anterior-posterior direction. But when the tongue is small or rudimentary, the force exerted by the tongue is absent and it fails to develop in anterior-posterior direction. As the mandible does not grow in anterior direction, it leads to further dentoskeletal malocclusion. This is being the consequence of aglossia or the microglossia. There is no any predilection for gender, especially for male or female. There is no any as such. Its etiology must be searched for in some sort of fetal cell trauma during initial weeks of gestation. This has been just predicted. So the treatment modalities mainly depends on the nature and severity of the condition. For the severe dentoskeletal malocclusions, surgery or orthodontic treatment is required. And in patients with speech therapy or disturbed, they need to undergo a speech therapy. Macroglossia, it is also known as tongue hypertrophy, enlarged tongue, or pseudomacroglossia. Macroglossia means a large tongue and has been documented in since several centuries. Although the exact incidence of macroglossia is unknown, some congenital syndromes often expresses macroglossia in their phenomena, such as Down syndrome and Beckwith-Wiedemann syndrome. In Beckwith-Wiedemann syndrome, 97.5% of the patients have reported with the macroglossia. So let's discuss the causes for the macroglossia. We have listed them as the congenital causes and the acquired causes. The congenital and the hereditary causes being the vascular malformations, lymphangiomas, hemangiomas, hemihyperplasia, cretinism, Beckwith-Wiedemann syndrome, Down syndrome, mucopolysaccharidosis, neurofibromatosis type 1, multiple endocrine neoplasia type 2B variety. And the acquired causes being the edentulous patients, amyloidosis, myxedema, acromegaly, angioedema, carcinoma, and other tumors. It commonly occurs in children and range from mild to severe. In infants, it presents with noisy breathing, drooling, and difficulty in eating. Sometimes patients present with lisping speech. Tongue presents with crenated lateral border. As the size of the tongue is larger, so it tends to put a pressure on the dentoalveolar arch and it gets the indentations of the teeth on its lateral border, creating a crenated lateral border. As the tongue puts pressure on the anterior teeth, there will be open bite, mandibular prognathism, mandible overgrows in forward direction or the anterior direction. If the tongue constantly protrudes from the mouth, there are chances of ulceration and become secondarily infected, or even it may undergo necrosis. Very severe cases presents with airway obstruction. So what is macroglossia? Why the tongue becomes large in size and how it becomes? One is the dilatation of the lymphatics, the lymph supplying to the tongue. It dilates. And there is a muscle hypertrophy. The muscle cells enlarge in size, hypertrophy. And sometimes there are chances of inflammation. It leads to fluid accumulation and thereby increasing the size of the tongue. It presents clinically in two conditions, that is the true macroglossia and the pseudomacroglossia. How to differentiate whether it is true macroglossia or the pseudomacroglossia? For this, a thorough physical examination of the oral cavity and head morphology is helpful to decide the true macroglossia from the pseudomacroglossia. There is severe retrognathia and usually small maxillary or mandibular size may indicate the macroglossia. In addition, check tongue for Tone and mobility to rule out simple atonia, that is a lack of tongue, or hypotonia, that is decreased tonicity of the tongue, indicating poor posturing of the tongue, as commonly observed in Down syndrome. So these are the features to look for being a clinician when patient walks into with a macroglossia. In addition to the oral cavity and airway, assess other features of the patients for congenital and systemic syndromes. So main treatment for the patients with the macroglossia, the goal is to reduce the tongue size and thereby improving the function, which is of main concern to the patients. The functions include the articulation, mastication, deglutition, and protection of the airway and gustation. In case of symptomatic patients, reduction glossectomy is performed. Ankyloglossia or tongue tie. It is more commonly said to exist when the lingual frenum or the inferior frenum attaches to the bottom of the tongue, and subsequently it restricts the movements of the tongue. Sometimes the frenum attachment will be till the tip of the tongue and it completely restricts the movement of the tongue laterally, even anterior posteriorly. So it occurs with the male predominance. Total or complete ankyloglossia, where the ventral surface of the tongue is fused to the floor of the mouth. And partial ankyloglossia, there is a presence of short lingual frenulum. So here you can appreciate the partial ankyloglossia and the total complete ankyloglossia. Approximately 1.7% of all the neonates without preference, they report with the ankyloglossia. With growth, the frenulum lengthens, so normal tongue function is established in few. The criteria for diagnosis is based on the observation of the lingual mobility. Simple incision of the frenum results in development of the scar tissue and further restriction of the tongue movement. In some cases, the frenulum is reported to tear spontaneously during infancy. Tongue tie in some patients can cause feeding problems, especially in infants. If this is the case, feeding difficulties are usually noticed in the early phase of infant's life. If the patient encounters with the feeding difficulties, early surgery to cut the lingual frenum and loosen the tongue is performed. In some children, tongue tie may also cause speech defects. In such cases, surgical intervention is required. In severe cases associated with upward and forward displacement of the epiglottis and larynx, resulting in various degrees of dyspnea, that is difficulty in breathing, the tongue is remarkably able to compensate sometimes. It depends, the severity depends on the extent to which the tongue is fused to the floor of the mouth by the lingual frenum. In some cases, what happens, the tongue is remarkably able to compensate. Many children have no speech impediments due to ankyloglossia. Tongue tie may contribute to dental problems such as persistent gap between the mandibular incisors. So the treatment depends on the severity. In infants, frenotomy or clipping or simple release of the frenulum is performed so that it will not affect the feeding. In children and adults, frenuloplasty, that is release with the plastic repair, is performed. In adults, if it still persists and if it is causing more complications, then frenectomy is the treatment of choice. Cleft tongue. A complete cleft or bifid tongue is a rare condition due to lack of merging of the lateral lingual swellings of the tongue. There is a failure to fusion of the lateral lingual processes. In partial cleft, considerably it is more common and manifested simply as a deep groove in the midline of the dorsal surface. Because of incomplete merging and failure of groove, obliteration by underlying mesenchymal proliferation. Interestingly, it is often found as one of the features of orofacial digital syndrome. It presents with thick fibrous bands in the lower anterior mucobuccal fold, eliminating the sulcus and with clefting of the hypoplastic mandibular alveolar process. So if a patient presents with such condition, the main attention should be given for the oral hygiene, as the food debris accumulation and microorganisms may collect in the base of the cleft, causing the irritation. So it is always stressed on maintaining a proper oral hygiene. Fissured tongue. It is also called as scrotal tongue, Lingua Plicata. A condition frequently seen in general population. It is characterized by grooves that vary in depth and are noted along the dorsal and the lateral aspect of the tongue. A definitive etiology is not known, but polygenic mode of inheritance is suspected. Polygenic mode means more than one gene is involved. Patients are usually asymptomatic and the condition is initially noted on the routine intraoral examination as an incidental finding. Patient will not complain of anything as such, but it will be just diagnosed as an incidental finding. Fissured tongue is associated with Merkerson-Rosenthal syndrome, Down syndrome. Frequently, it is associated with benign migratory glossitis, which is also called as geographic tongue. Merkerson-Rosenthal syndrome, a rare condition consisting of a triad of persistent or recurring lip or focal swelling, intermittent seventh nerve paralysis, and fissured tongue. The etiology of this condition is unknown. The orofacial swelling usually manifests as pronounced lip enlargement. Lip enlargement may or may not affect both the lips, but it may be tender or erythematous. Histologically, it shows the characteristic non-caseating granulomatous inflammation. Therapy for these lesions is often intralesional steroid injections. The facial paralysis is indistinguishable from the Bell's palsy and it may be on inconsistent and intermittent finding with the spontaneous resolution. Clinically, the prevalence worldwide varies by the geographic location and has been reported to be as high as 21% among all the dental disturbances of tongue. Fissured tongue is totally a benign condition and considered by most to be a variant of normal tongue architecture. There is no sex predilection, but some have reported a slight male predilection to occur. Although fissured tongue may be diagnosed initially during childhood, it is diagnosed more frequently in adulthood. The prominence of the condition appears to increase with increasing age. The lesions are usually asymptomatic unless debris is entrapped within the fissures or when it occurs in association with the geographic tongue. Fissured tongue affects the dorsum and often extends to the lateral borders of the tongue. The depth of the fissures varies anywhere between 2 to 6 millimeter in diameter. When particularly prominent, the fissures or the grooves may be interconnected, separating the tongue dorsum into what may appear to be several lobules. Although the specific etiology has not been elucidated, but the polygenic mode of inheritance is suspected. Histologically, biopsy is performed in case of the fissured tongue very rarely. An increase in the thickness of the lamina propria is seen, that is with the loss of filiform papillae on the surface of the mucosa, hyperplasia of the retipex, there is formation of microabscesses, neutrophilic microabscesses within the epithelium, and mixed inflammatory infiltrate in the lamina propria. The treatment includes, there is no any definitive therapy or medication. Median rhomboid glossitis. As I have briefed you regarding the development of the tongue in my previous slides, tongue is developed by the two lateral processes. There will be fusion in the midline and fusing above the central structure from the first and second pharyngeal arches, the tuberculum impar. The tuberculum impar and the two lateral lingual processes fuse. The posterior dorsal part of fusion is occasionally defective sometimes, it leading to a rhomboid-shaped smooth erythematous mucosa lacking the papillae and the taste buds. Median rhomboid glossitis is a focal area of susceptibility to recurring or chronic atrophic candidiasis. Sometimes it is also referred to as posterior midline atrophic candidiasis. This term has certain difficulties because not all the cases improve with the antifungal therapy or show the initial evidence of fungal infection. The erythematous clinical appearance, moreover, is due primarily to the absence of the filiform papillae rather than the local inflammatory infiltrate. The lesion is found in one of every 300 to 2000 adults. It is seldom biopsied unless the red discoloration is confused with the precancerous erythroplakia or its surface shows pronounced nodularity. Clinically, it presents in the posterior midline of the tongue, just anterior to the V-shaped grouping of the valid papillae. The long axis of the rhomboid or oval area of red depapillation is in the anterior-posterior direction, as the photographs depict. Most cases are not diagnosed until the middle age of the affected patient, but the entity is of course present since the childhood. It appears with a male predominance in a ratio of 3:1. The picture showing the median rhomboid-shaped depapillation in the anterior-posterior direction. Can see here. Those lesions with the atrophic candidiasis are more erythematous and some respond with excessive keratin production and show a white surface change. Infected cases may also demonstrate a midline soft palate erythema in the area of routine contact with the underlying tongue involvement. And this is commonly referred to as the kissing lesion. These are typically less than 2 cm in greatest dimension and most demonstrate a smooth, flat surface, although it is not unusual for the surface to be lobulated. Occasional lesions are located somewhat anterior to the usual location and have been reported posterior to the, none have been reported posterior to the circumvallate papillae. prior to biopsy, the clinician should be certain that the midline lesion does not represent lingual thyroid, as sometimes it is the only thyroid tissue present in the body. So, the clinician must differentiate between the lingual thyroid and median rhomboid glossitis before going to biopsy. Histological features. The median rhomboid glossitis shows a smooth or nodular surface covered by atrophic stratified squamous epithelium overlying a moderately fibrosed stroma with some dilated capillaries. The fungiform and filiform papillae are not seen. Mild to moderately intense chronic inflammatory cell infiltrate may be seen within subepithelial and deeper fibrovascular tissues. Chronic candidal infection may result in excessive surface production of keratin, individual cells, and premature keratin production as epithelial pearls deep in the process. So to differentiate the candidal infection, silver staining for fungus will often reveal candidal hyphae and spores in the superficial layers of the epithelium. Pseudoepitheliomatous hyperplasia may be quite pronounced, and the tangential cutting of such specimen results in artificial appearance of islands of squamous epithelium, leading to mistaken diagnosis of squamous cell carcinoma. So this is very important to differentiate between the actual squamous cell carcinoma and pseudoepitheliomatous hyperplasia. Because of this difficulty, it is recommended that patient be treated with topical antifungals prior to the biopsy of the median rhomboid glossitis. No definitive treatment is necessary for patient, but nodular cases are removed for the microscopic evaluation. Recurrence after removal is not expected, although those cases with the pseudoepitheliomatous hyperplasia should be followed closely for at least a year after the biopsy to be certain of the benign diagnosis. Antifungal therapy will reduce the clinical erythema and inflammation due to candidal infection. This therapy should ideally be given prior to the biopsy, and some lesions will disappear entirely after the antifungal therapy. Benign migratory glossitis or geographic tongue. It is a psoriasiform mucositis of the dorsum of the tongue. Dominant characteristic is constantly changing pattern of serpiginous white lines surrounding the area of smooth depapillated mucosa. The changing appearance has led some to call this a wandering rash of the tongue, with the depapillated areas have reminded others of the continental outlines on the globe. The use of popular term geographic tongue is, as with the psoriasis, the etiology of benign migratory glossitis is unknown, but it seems to become more prominent during the condition of psychological stress and psoriasis of the skin. It shows increased frequency up to 10%. The great majority of those with the oral involvement, however, lack psoriatic skin involvement. 1 to 2% of the population is affected, although most cases are so mild that they are never formally diagnosed. All of the microscopic features of psoriasis are present in this condition, but these will not be obvious unless the biopsy is performed from the prominent serpiginous line at the periphery of the depapillated patch. A thickened layer of the keratin is infiltrated with the neutrophils. These inflammatory cells often produce small micro abscesses, which are called as the Monro's abscesses. These are present in the spinous layer. Rete ridges are typically thin and considerably elongated, with only a thin layer of epithelium overlaying connective tissue papillae. When the rete ridges are not elongated, the pathologist should consider the Reiter syndrome as a diagnostic possibility. The chronic inflammatory cells can be seen in variable numbers. The silver or periodic acid strip staining will often demonstrate the spores and the hyphae in the superficial layers of the epithelium. There is no ulceration except in case of the Reiter syndrome. Usually, no treatment is required for benign migratory glossitis. Symptomatic lesions can be treated with topical prednisolone. Occasional symptomatic cases respond well to topical tetracycline and broad-spectrum antibiotics. Hairy tongue. It is commonly observed with the desquamation of the filiform papillae, most frequently referred to as the black hairy tongue. However, it may also appear in blue, white, brown, white, green, and pink variety of hues, depending on the specific etiology and secondary factors, such as the colored mouthwashes, breath mints, and the candies. These are the classic pictures of the black hairy tongue. The basic defect in hairy tongue is the hypertrophy of the filiform papillae on the dorsal surface of the tongue, usually due to lack of mechanical stimulation and debridement. This condition often occurs in individuals with poor oral hygiene, that is, lack of toothbrushing, eating a soft diet with no roughage that would otherwise mechanically debride the dorsal surface of the tongue. The contributing factors being the use of the tobacco and drinking coffee or tea. Normal filiform papillae are 1 millimeter in length, whereas in case of hairy tongue, they are more than 15 millimeter in length. Hairy tongue has been reported with greater frequency in males with human immunodeficiency virus and those who are HIV intravenous drug users. Rarely it is symptomatic, although overgrowth of Candida albicans may result in glossopyrosis, that is burning sensation of the tongue. Patients frequently complain of tickling sensation in the soft palate and oropharynx during swallowing. In more severe cases, the patients may actually complain of gagging sensation. It is because of the elongation of the filiform papillae. When it contacts the soft palate, it leads to the tickling sensation and the gagging sensation. Retention of oral debris between the elongated papillae results in irritation. The tongue has a thick coating in the middle with the greater accentuation towards the back. Bacterial and fungal overgrowth plays a role in the color of the tongue. The only complication associated with hairy tongue is an occasional overgrowth, which often results in uncomfortable glossopyrosis. Altered taste sensation is a rare complication. This condition has to be differentiated from the candidiasis, leukoplakia, oral lichen planus, and oral hairy leukoplakia. Culture of tongue's dorsal surface may be taken to differentiate between candidiasis and other specific infections. Distinction between oral hairy leukoplakia and hairy tongue is carried out by a simple punch biopsy and immunostaining of the specimen for the presence of Epstein-Barr virus is performed, which is associated with oral hairy leukoplakia. Histologically, it shows elongated filiform papillae, mild hyperkeratosis, occasional inflammatory cells, debris accumulation along the papillae and candidal pseudohyphae. The treatment of the hairy tongue is variable. With which severity it presents, the treatment modalities are followed. In many cases, brushing of the tongue with the toothbrush or use of the tongue scraper suffice. Surgical removal of the papillae using the electrodesiccation, carbon dioxide laser, or even scissors is the last sort of treatment modality. If the precipitating factors cannot be adequately controlled or compensated for, patient may have to make tongue brushing or scraping as a part of daily oral hygiene regime. Lingual varices. Varix is a dilated tortoise vein, most commonly a vein which is subjected to increased hydrostatic pressure but poorly supported by the surrounding tissue. Involving the lingual renine veins and relatively common, appears as red or purple, short like clusters of vessels on the ventral surface and the lateral borders of the tongue as well as in the floor of the mouth. Varices also do occur in other oral sites such as the upper and lower lip, buccal mucosa and buccal commissures. There has been no direct association established between these lesions with any systemic or other diseases. These represent an aging process common in people older than 60 years. It may be associated with leg varicosities. Thrombosis of any of these varices is relatively a frequent occurrence. Histologically, it presents with dilated veins, the wall of which shows little smooth muscle and elastic tissue. Secondary thrombosis occurs. The lumen contain concentrically layered erythrocytes are also present. The clot undergoes organization via granulation tissue with recanalization. Older thrombi may shows dystrophic calcification, that is the calcification which occurs in dead or degenerated tissue. There will be deposition of the calcium resulting in the formation of the phlebolith. Phleboliths are nothing but the small blood clots in the vein that undergo calcification. Lingual thyroid nodule. The thyroid gland develops in the embryo from the ventral surface by means of endodermal invagination. The tongue forms at the same time from this as the pharyngeal floor associated with the thyroid gland by the connection through the thyroid lingual remnant of which is known as the foramen cecum. The lingual thyroid is an anomalous condition in which the follicles of the thyroid found in the substance of the tongue, possibly arising from the thyroid, it fails to migrate to its predestined position. The benign enlargement of lingual thyroid tissue is thought to be functional insufficiency of the chief thyroid gland. Other cases of lingual thyroid nodules occurs in patient residing in goitrous region, but it is not certain that the condition is a form of goiter. In addition, it has been suggested that the failure of the primitive thyroid gland descent is the cause of the majority of the cases. The incidence of this benign condition is not known, though information is inadequate about the racial and geographic lingual thyroid nodules. A difference in gender incidence does exist. So male to female ratio is being 1:7 with the female predominance 7 times than the male. The majority of the patients had their onset of symptoms relatively early as during puberty, adolescence and early maturity has been recorded. Salk carried out a study to determine the frequency with which ectopic thyroid tissue occurred in the tongue of normal person. In a series of 200 consecutive necropsies, ectopic thyroid tissue was found only in 10% of the cases, with equal distribution between the sexes. Since the condition is more often clinically apparent in females, he suggested that hormonal factors may be involved in genesis of the symptoms. It may be manifested clinically as a nodular mass in the tongue in general vicinity of the foramen cecum, commonly appears as deeply situated rather than the superficial. In some cases, it may appear vascular, while in others, the normal color of the mucosa it appears. The lesion is approximated to 2 to 3 centimeter in diameter. The chief symptoms being the dysphagia, that is difficulty in swallowing, dysphonia, difficulty in speaking, dyspnea, that is difficulty in breathing, hemorrhage with the pain or fullness in the throat. Histologically, the benign lingual thyroid nodules present a variety of microscopic features. The majority resemble the normal thyroid tissue or the embryonal or fetal type thyroid tissue. In some instances, the nodule exhibit colloid degeneration. Great care must be taken to distinguish these lesions from the accessory salivary glands in the same location. Both the lingual thyroid and the salivary glands gives rise to adenomas and adenocarcinomas. So whenever there are patients with adenomas and adenocarcinomas, the distinction is mandatory. So before treating the patient, the care must be exercised in handling the lingual thyroid lesion. Careful physical examination should be performed to demonstrate normally located thyroid gland in patients with the lingual or sublingual area. If the thyroid gland cannot be palpated, in such cases, CT scan is performed with the radioactive iodine and it will determine the normally located thyroid gland. It is usually recommended that patients with ectopic thyroid should have a trial of replacement thyroid hormone therapy, since this will often decrease the size and minimize the surgery. Occasionally, the clinical manifestations of the lesion necessitate the surgical excision. So the treatment modalities should follow the careful investigations and the needed treatment modalities. So here I come to an end of the session, the developmental disturbances of the tongue. Any doubts? My free Telegram group is open for the discussion. You can drop me in the feedback, as well as any doubts you can just text me. So big thank you to one and all. This is my contribution for your study journey. So CM Dental Academy, we have formulated a BDS module for the BDS third year students, especially in oral pathology and microbiology. The module 1 consists of 25 live online lectures. The lectures will be formulated from all the standard books recommended by the DCI. So you need not to refer multiple books. All the important points will be gathered at one station. The session recordings will be available for you all throughout the year. You can listen to them and revise your topic anytime. Targeted revision at the end of the module. At the end of the module, the targeted revision will be there pertaining to the topic. The online notes will be available. Viva OC points will be available. Even the MCQs respective to the topic will be discussed in thorough. So you can prepare for your university exams as well as for your competitive exams. The important histological slides will be discussed in thorough, and you will have a free library access throughout the year. So for further details, you can contact me. So here I conclude, success is a journey and it is not a destination. CM Dental Academy is always there to help you all. So what are you waiting for? Come, let's join us, a journey towards the success. Thank you all.
Thank you, ma'am.